Perfect. So, good evening, everyone. Thank you very much for attending this event sponsored by Synergix Med. It's truly a pleasure to have such distinguished individuals among our attendees. And of course, it's an honor to be part of a webinar led by Dr. Pooja Chopra, who has extensive experience in the topic she will be presenting to us today. My name is Oscar, and I'm joined today by Amber from the marketing department. We'll both be happy to assist you with any questions you may have in the message box and, of course, in the Q&A section. And now I'll conclude this introduction to turn you over to the expert, Dr. Pooja Chopra. Thank you, Doctor.
Perfect. Hi, everybody. I'm Pooja Chopra. I'm a double board certified PM&R and pain doctor, also specializing in traumatic brain injury. So thank you, Oscar, for the introduction. So today's talk and presentation is going to be about spinal cord stimulation. So let's start with the basics. What is spinal cord stimulation? It's a neuromodulation therapy used to treat chronic pain. It consists of a trial process, and if successful, we would proceed with implanting a small device, and this delivers electrical impulses to the spinal cord. The way spinal cord stimulation works is that these impulses, which are the percutaneous epidural leads, modulate pain signals before they reach the brain. So it thereby reduces the perception of pain. So SCS, it's a non-drug FDA-approved pain therapy. It's been shown to be very safe, and multiple studies throughout the years they pretty much have proven for it to be an effective therapy. It's been in use for over 40 years now. Like I said, multiple good quality, large studies over the years have shown how effective it is and how many thousands of people have now experienced pain relief because of this treatment modality. One of the great benefits of this is that it is minimally invasive. So why is that so great? I love that point because I always tell patients, listen, there's very minimal and very small incisions. What that leads to, the benefits are, less downtime, faster time for recovery, because they're smaller incisions. If you just look at as a whole, the smaller the incision, the less the chance for infection. So all in all, a lot of positive features because it is minimally invasive. SCS has been, it can be tested first to determine the effectiveness before implanting. So that is referring to the trial process again. So this is very unique, and I like to highlight this to this point to my patients because I will tell them that, how many surgical procedures are there that really allow this feature where you can actually trial this, and for whatever reason, whether you want it or not, you get to experience how much pain relief you get. So I think this is a very unique and honestly a great feature. It is fully reversible. So I haven't really seen that yet. And I mean, I guess I've done battery exchanges because of the IPG battery. Life is typically about 8 to 10 years. But if you theoretically want to think about it, it is fully reversible. And so if for whatever reason we do need to take it out, it definitely is an option. SCS has been a clinically effective and cost-effective option for chronic pain patients. So there's been multiple studies actually regarding this, and it's really interesting because when you think about SCS and, you know, a lot of people in various, aspects of it, patients, insurance companies, you know, whatever it is, whatever side you're looking at it, it does look like a high initial number because of the OR costs, the device costs, and all of that. But when you compare it, such as these studies have, over time, if you look at the long-term effects of pharmacologic regimens and the cost of that throughout the years, SCS is actually a more cost-effective treatment modality, which I think is great. there's new and a lot of new improvements in technology, and that has led to dramatically improved patient results. So whether that's burst, high frequency, the alpha fast system, there's just so many different treatment modalities now that have led to even greater success with this with SCS. Most devices are now MRI compatible, which is great because initially a lot of them were not. And for patients who need serial MRIs or routine MRIs, this was becoming an issue. So, you know, I think a lot of the companies have noticed that that was an interference in patients being able to proceed with this therapy, but now that has been addressed. So let's talk about the mechanism of action. So SES, it works by stimulating the dorsal column of the spinal cord, and this is how it interferes with the pain signal transmission. So the most rudimentary and basic theory, there's a lot of different, it's a very highly complicated and complex mechanism of action, but this is probably the most simplistic version we have, which is the gate control theory. And it suggests that there's non-painful stimuli, which we call paresthesia. These electrical impulses close the gate to painful input. So essentially, the way I describe it to patients is, you know, if you hit your funny bone on something and you feel that sudden onset of pain, well, we've all experienced that, I think, at some point. And what do? We rub our elbow. So whether we realized it or not, that essentially is what the gate control theory is suggesting, where you're um, transmitting other stimuli, which is touch in this case, and that's interfering with the pain signal that our brain is perceiving, thereby reducing the pain. So, modern SCS systems use different waveforms, whether that's tonic, burst, high frequency, and all of these and different reprogramming techniques and strategies have shown to optimize pain relief. So this is just a more detailed schematic of what we talked about with there's the Melzack and Wall theory, which is the original gate control theory, and there were some updates with the Hillman and Wall. So all of this is talking about is when you look at the pain signal, and here's the dorsal columns to the left, and so this is transmitting that pain signal and how the alpha beta receptors kind of interact and interfere with that to reduce the perception of pain. So let's talk about the advancements in stimulation technique. So, like we briefly addressed earlier, burst stimulation significantly reduces the pain intensity and improves patient-reported outcomes. This is one newer treatment modality that has come up in the past, I would say, about 10 years or so. And we've seen a lot of patients do really well with this. High frequency is another programming technique. And it actually is now FDA approved for painful diabetic neuropathy, in addition to other just basic spinal cord stimulation indications. So we'll talk about those in a bit, but it has shown to significantly reduce pain and thereby improve the quality of life for many patients. So who benefits from spinal cord stimulation? So there's multiple different pain conditions, and I would say probably the most common is failed back surgery syndrome, for which we put spinal cord stimulation. But there's also CRPS, which is complex regional pain syndrome, neuropathic pain, which can include diabetic neuropathy as well as post-herpetic neuralgia, which is more like shingles-related pain, chronic radiculopathy or sciatica, as well as peripheral vascular disease pain. So this is actually really interesting because for peripheral vascular disease, I actually had a case presentation regarding this where we put spinal cord stimulation for chronic radiculopathy, but the patient also was a cardiac patient. And we noticed the patient was actually doing a lot better from a cardiac standpoint because of the increase of blood flow as a secondary benefit that we've noticed. So that was very interesting. But I would say, all in all, failed back surgery syndrome is probably the most common indication. CRPS, I think almost every pain physician has dealt with at least one debilitating pain patient that has CRPS. This can be seen in traumatic situations as well. There's two types. So this is a big, kind of a big thing for us because having this treatment modality sometimes is really the only thing that has helped patients because some cases of CRPS or CRIPS is just so debilitating for some people. So what this entails is the whole spinal cord stimulation process. We'll start with, first we'll see patient selection is very important, obviously, and we'll see, what is the etiology or the underlying cause of the pain. And if we think that spinal cord stimulation would be a good treatment modality, we first start with psychological testing. There is no hard and fast rule with this testing, but we do typically like to have a psychologist, ideally or optimally a pain psychologist, and they'll help assist us in screening before device implantation. And, you know, we haven't found, like I said, a formulative standardized test to do this, but there's various factors and variables that they will assess to help us understand whether spinal cord stimulation would be a good treatment modality for this particular patient. So when you look at when a patient does have a successful psychological test done and the psychologist does recommend for the patient to proceed with spinal cord stimulation, the next step is the trial. So it's a pretty straightforward procedure, usually consisting of two percutaneous epidural leads that are placed in the epidural space. So it's pretty similar in that regard to an epidural injection. However, as opposed to an epidural injection, which is a single shot of medicine, we're now putting these epidural leads in that space. And so these leads are connected to an external it's an EPG battery essentially. So instead of implanting the battery internally, which is what the permanent implant consists of, for the trial, we just have the leads connected to an IPG, which the patient usually just wears across their waist, kind of like a fanny pack. So the trial typically lasts about 5 to 7 days, and patients can go about their lives experiencing the benefits of SCS. So this is a very important point that I want to address because I do get some patients who are on the fence, and I have experienced that, and I have no problem. I'll go into all the details of what SCS is, the trial process, everything I've been talking about thus far. But and I'll also explain all of the different trials and studies that have been proven to be successful, just so I can give them all the information to make an informed decision for themselves. However, I also, once again, want to highlight to patients that the beauty of this is they get to experience the trial and see for themselves, how beneficial it is. And thereby, to what degree does it improve their quality of life? And I think that in itself is such a amazing aspect of this treatment modality because, like I said, it's very hard for or a patient undergoing any other kind of surgical procedure to have the ability to kind of experience that and have that trial period. And for those patients who are or have been indecisive that I've encountered, I can tell you after the trial, um, they pretty much have a really good idea of how they want to proceed. So it's kind of nice in that regard to give the patient that autonomy and really have them be in the driver's seat for this. So pretty much it lasts about 5 to 7 days typically, and then we always have to pull out the leads. Even I always tell patients, even if it's the most successful trial ever, you don't have any pain anymore, I still got to take it out, okay? Because there is a risk of infection because those leads are not placed correctly in the sense of they're not sewn in. It's externally connected to an external battery generator. So for that reason, regardless, even if it's the best trial, we still have to take it out. But the next step is, if it is successful, we will proceed with permanent implant. So how do you know if the SCS trial worked for you? These are just basic parameters, but we want to see at least pain reduction by 50%. And a big thing in pain management is pain relief, but also quality of life. So we are really looking at, are you able to get back to your daily activities, your how, things that make you happy, that fulfill your quality of life? That's equally important to us. Is your need a good way to determine how much improvement you get is, I always tell patients, take a look at how much pain medication you are requiring before the trial and think about how much, kind of pay attention to that and see how much are you requiring with this trial. Um, and then lastly, if you're able to relax and sleep better, those are obviously all indications that overall the pain is improving. So these are things to important considerations. So if the patient has a successful trial, we'll proceed with scheduling for a permanent implant. This consists of two percutaneous SCS epidural leads and an IPG placement, which is the battery. And this is placed subcutaneously. So we'll connect, once we place the epidural leads, we'll connect it internally to that IPG. Like I said, minimally invasive procedure, which is so amazing for patients. And the beauty of this is a lot more important than what I initially thought, but I understand it now that, the first thing patients would ask me when I would describe this procedure is, well, doc, how long do I have to be in the hospital? And it's my favorite thing to say, you can go home that day, the day of. So there's really shouldn't require a hospital stay or a hospital admission. So let's talk about the clinical evidence and efficacy. So there's been multiple studies. They've shown that SCS has provided significant pain relief for about 50 to 70% of patients. High frequency SCS specifically has demonstrated superior pain relief compared to traditional SCS. And long-term studies suggest that SCS improves the quality of life and reduces opioid dependency. This is great for the opioid pandemic or that we have been facing for quite some time now. It kind of puts us in a bind because there are some patients who benefit from opioids, but we're limited as providers with what we can do. And in addition to that, there's so many side effects. Some patients just don't tolerate opioids, and that is the limiting factor of, even if we do have room to increase it because of the side effect profile, itching, constipation, potential for addiction, all of those are limiting factors. So these are all important points. So let's talk about the risks and limitations. So potentially there's a risk for lead migration, infection, and hardware malfunction. Luckily, with proper protocol and sterile technique, and these are extremely low, but nevertheless, we are aware these are the potential complications that can occur. Um, Oftentimes there can be, reprogramming, especially initially, until we can get the right setting for that patient. And sometimes patients can experience, some with that adjustment, some mood related issues. But usually these, like I said, I haven't had too much of an issue with any of this. Patients usually are pretty understanding about, we're going to work with you and get that right programming technique to work for patients and their pain improvement. So let's talk about the benefits of SCS. So we've briefly touched on this, the impact of medication use. It has led to a reduction in opioid consumption and increased utilization of non-pharmacologic therapies. Cost effectiveness. So yes, there is that high initial cost. Over time, SCS is cost effective in the long term due to the reductions in pain-related healthcare utilization, as well as the improved quality of life. So while it does have that steep initial cost, if you look at the long-term, use and the cost and less ER visits for uncontrolled pain, medication costs, all in all, this is cost effective. So SCS is an effective treatment for chronic pain patients, particularly neuropathic pain. Patient selection is key. For those with neuropathic pain, failed back surgery syndrome, and CRPS, those patients benefit the most. And ongoing research aims to improve device technology and thereby optimizing patient outcomes. So I'm going to open this up now to questions.
Hello, can you hear me, Dr. Chopra?
Yeah.
Perfect. The first question that we have over here, it's by Dr. Satish Apte.
Mhm.
The question was, what is your experience with closed loop CSS, like inceptive, and is it really any better than open loop stimulation?
No, that's a great question. So, one of the newer advancements for people who are not aware of closed loop versus open loop is, it has shown to have increased efficacy. I think once again, it really does come down to patient selection and seeing, um, the different variations. But I personally have started, but I haven't done enough to really say, hey, I'm not gonna, this one is the game changer, closed loop. It's definitely way better to the point where I don't use the traditional SCS. So I think definitely more research. I'm excited to see kind of where it goes within the space, so we have a better idea. Right now, I think there's definitely a role for it, but I'm not, if that makes sense, I'm not completely sold on this is the best and it's going to substitute open loop.
Thank you so much for that answer. I have also another one from Dr. Satish Apte. He says, is the stimulator implant in the dorsal root ganglion better for chronic pain that is more localized to one or two roots for CRPS?
That's a great question. So traditionally, I would have said that dorsal root DRG SCS is has shown to be better for CRPS, especially because traditionally we were having a lot of trouble getting stimulation for like lower leg foot, particularly for foot and ankle. So in those cases, especially sometimes where those patients manifested as that was where their CRPS manifested, that was becoming an issue. However, some of the newer programming, even with traditional dorsal column stimulation now, I've personally experienced that, and the studies have shown that actually are able to target that area that we haven't previously been able to cover. But I will say DRG, SES is better than traditional, or I like it better. And kind of following the evidence for pelvic pain. So for chronic pelvic pain, that is one modality that I would probably lean more towards DRG at this time than traditional.
Thank you so much. I also have an anonymous question. How does this process affect the quality of life beyond just pain relief, like my sleeping cycles, mood, or daily activities?
Um, so if I'm understanding the question, you're asking that how does it specifically, in addition to pain relief, how does it affect mood and sleep, correct?
Yes, correct.
Okay. So we have seen with chronic pain that, up to 50% of it is linked with depression, anxiety. It's kind of a vicious cycle. I mean, when you look at when you're in pain, even for a few days, let alone chronic pain, which the technical definition is at least 6 months of persistent pain. That really changes a person. So typically, pain, it's not just pain related. It starts seeping into every aspect of your life. That includes sleep, because a lot of patients, I've yet to find a pain patient, especially a chronic pain patient, who is telling me, oh, they're getting A+ quality sleep. That to me, I don't think that exists. So hard to get comfortable is what I often hear from patients, often waking up multiple times a night, having trouble falling asleep. So all of that. And then if you think about pain, now you're also having insomnia issues in addition to the pain. Well, the two of those definitely are affecting your mood now. So, like I said, the incidence of depression and anxiety is as high as 50% in chronic pain patients. So if we can get that pain improved, typically mood is better, sleep is better, and that's what the evidence shows. And anecdotally, that's what I've seen in my practice as well.
Thank you so much. I also have another question from Dr. Satish Apte. He says, what is the last report if DCS fails? Does morphine pump still has a role to play?
Great question. So I actually historically have done a lot of pain pump implantations as well as SCS. So in certain patients, I mean, this like any other treatment modality, I would say it's patient selection, right? SCS is a great treatment modality, but it may not be the best for every single patient. You can't just put it across the board. So we often look at a lot of factors. There's a lot with SCS, a lot of programming, the remote, the technicalities. Some of our patients are, it's a little complicated. They're not there yet. They don't want to deal with the constant reprogramming. They don't want to deal with the remote. They just want the machine to kind of do their thing, in those cases. Um, SCS may not be the best treatment modality, right? So, I have used pumps. I have used other device. Just it comes down to, what is the first of all, I would say, what is the pain diagnosis? What is the etiology or the underlying cause of the pain? And if even if SCS would be theoretically a good treatment modality, there's other aspects, which is where the psychological testing also helps, in addition to a thorough and comprehensive history that we often talk with patients and explain everything, explain the procedure, what it entails, how your day-to-day life typically looks like, especially in the beginning. And, we had that conversation, and that's where we kind of come up with, okay, well, this is a great treatment modality, or, maybe not the best treatment option for this patient. So in those cases, I have used intrathecal pain pumps as an option if they have, hypertrophy ligamentum flavum resulting in neurologic claudication symptoms. I'll do the mild procedure, just to name a few of many. So we do have treatment options, is the short answer, if not SCS.
Thank you so much. I think I have the last question over here. Is there a limit to how long someone can use spinal cord stimulation, either in terms of age or device longevity?
That's a fantastic question. So, age related, no. There's no hard and fast, oh, here, X amount of age, so sorry, we can't do this on you. Once again, we'll talk to patients about, we'll sit down, have that conversation, explain what the procedure entails, what is the immediate post-procedural couple weeks looking like, the reprogramming that they may have to come to the office or talk to their rep a little bit more frequently until we can get them on the right program. Some patients in the beginning, just one or two adjustments and they're great. So it is very variable, but I like to always talk to my patients, explain everything thoroughly. This is where your pain psychologist or the psychologist you're using to help with the psychological testing for SCS is good because they'll look at various parameters, and that's something maybe it gives me sometimes cues on what to hone in on before we talk about the actual trial and proceeding with it. So it all just varies. So not a hard and fast age-related cutoff. The device longevity. So I've had to do a few IPG generator, which is the battery exchanges, because they typically are about, I think, 8 to 10 years, or most companies usually say, I think, about 10. I've seen about closer to 8, where, it's not working at its peak optimizing way that it probably initially had. So that's when we'll kind of discuss doing a battery exchange so taking out the old battery and putting a new one and connecting it to the percutaneous leads. So I would say that's probably the biggest device limitation, in the sense of, that's the longevity, but the procedure really isn't that laborious, so not too big of an issue.
Thank you, doctor. Just wanted to mention that the microphone is also open in case anyone else have a question.
Hi, Dr. Chopra. Good evening. This is Satish Apte. And sorry about having so many questions, but
No, I love it. Fire away.
I'm extremely intrigued by this technology. And a while ago in a prior life, I decided to design one myself.
Oh, wow. Okay.
So, my question is, are these all now wirelessly programmable with Bluetooth or something like that? Because back then, Bluetooth was not available.
Yeah.
And then the second part of this question is, are these batteries chargeable by induction? Like you charge your iPhone wirelessly. So can you just like hold a pad next to the battery and charge it from outside without opening the patient up?
Um, that's a great question. Both are great questions. So for the first one, you have, so it is, from my understanding, you know, I can't speak for all the different device companies, but the ones I've seen, which I've used, don't really have a particular, I try to kind of be an open agent and not discriminate with one versus another in terms of company. And I just let the patient decide whichever one they want to proceed with. I've seen that most are wireless in the sense of it has to be close by, though. There are some technical, like in terms of charging. I think for the most part, it is very user friendly. And I believe now most are have wireless capability. I know one of the downsides with the high frequency initially was frequent charging because of that high frequency required kind of drained the battery a little bit fast. So I hope that answers that question. And then the second, can you repeat the second one more time? I'm sorry.
Yeah, the second question was, can the battery be charged wirelessly from outside with induction? Like
Oh,
we charge,
gotcha.
like we charge iPhone, we just put it on a pad. So can you
Yeah.
hold a pad next to the device from outside without opening the patient up and charge the battery?
So, okay. So I believe, I'm not 100% sure, but I believe that is how it is done now.
Hmm.
Um,
Dr.
I,
Chopra, do you want me to kind of
yeah,
chip in and
yeah,
help you?
Maran, if you have
Yeah, of
any
course.
follow
Yeah,
up,
yeah,
I'm
yeah.
not
So
100%
all these
about one.
batteries, I implant a lot of these devices too, and all these batteries, they are just like your wireless cell phone. They are wirelessly charged and rechargeable with. There are primary cells which don't need charging, but then they would need to be replaced more frequently. They don't last the 8 to 10 years on average. But yeah, all of them are rechargeable with wireless pads. They essentially have a wireless pad which is plugged into the power outlet that charges on its own. And when it's ready, when it's charged, it just gets put in a belt and patient wears it over the area where the battery is implanted. And for conduction, it just charges the battery, just like any other lithium battery out in the market.
Yeah, that's what I've seen so far. I just wasn't sure. And that is my understanding as well, that I haven't had
Yeah,
any
absolutely.
complaint about that.
Yeah, and there are several different aspects. You mentioned like the recharging, even yeah, you're absolutely right. With never charge rhythm was with a high frequency was a problem. But I have had a lot of patients in my practice. Just the pain relief they get from it, it makes it to become such an integral part of their life that it's totally worth it for them to go through that process with the pain relief they get, and also with the newer advances in technology. There's adaptive AI. There is much more sophisticated programming, which is working even towards making that charge burden even less, which is they're very exciting for all the advances that's happening. So it's only getting better as we move forward with this.
I 100% agree. And thank you, Murad. And also, I do want to add that, these companies are doing, they're listening, they're getting their feedback. They are making improvements every year. I think they're coming out with something new and improved. Certain companies like Boston will have the cloud. I think a lot of Medtronic, Abbott, all of these companies overall, Nevro, they all have like their version of the cloud. Essentially it uploads all of the patient data from each SCS machine and the generator into the cloud. So, when your rep or the local rep is looking at this, they have all of that information already kind of squared away. They can look at that even if they're remote. They're not by the patient. They don't have to interrogate the IPG to get that information at this point. That's already kind of automatically uploaded. So, they are making a lot of advancements, and all of this is, contributing to making, providing more relief, making this more user-friendly for patients as well. I hope that answered your question.
Yes, you're very knowledgeable in this, and thank you for your answers,
Oh,
both.
yeah, absolutely.
Yeah.
Dr. Chopra, actually, since we have several legal professionals in here,
Mhm.
would also like to hear your questions or experience with spinal cord stimulators, or maybe Dr. Chopra might also be able to share a specific case with our legal experts.
Absolutely. I mean, you're only going to hear good things from me about SCS. I've seen it, really transform lives. I've had a lot of patients, they were kind of stuck in this, more in the chronic pain world, but I've also seen it with, an acute injury and trauma leading to actually CRPS. And I've seen how it was a very debilitating case of CRPS. We tried, a lot of these, we tried the typical medications, therapy, even the injection therapy with stellate ganglion blocks or lumbar sympathetic blocks to help target, the sympathetic chain. But really, until we did that STEM trial, and, that to me is like my favorite part because, I really get to see that patient experience. Um, they get to experience it for themselves. So I've seen, I've had only good, like I can only say good things about it. I've seen it work with patients. I've also, I think the key is patient selection. Like I said, I'm going to drive this point home. Sorry if it's so repetitive, but that's really the biggest thing is patient selection, patient selection, patient selection. You got to make sure it's the right patient for this. It's not there's no blanket treatment that's a cure-all for every single patient. That's just not how medicine exists. That's not how these therapies exist. But that being said, if you go through that algorithm, you talk to the patient, you see this is where the main primary pain generator, where that etiology of pain is coming from. And SCS may be, a potential treatment modality. I'm always for being aggressive and trying and pushing for that trial for these patients. And there are those complications, but it's such a small percentage at this point that the risk versus benefit profile benefits are just so much greater at this point. So I really advocate for my patients to try to push this, even at least the trial, if or when at all possible.
Yeah, so I just want to double in that. I would say, like, I mean, the results I've seen with my patients, such life-changing outcomes that, and the best part about it is you get to test drive it without even committing to it. And there's nothing else out there in the world of spine surgery or pain that you can be so sure that this, this minor surgery is going to work for your patient so great. And, the long, I've had implants for patients who they come back like 3, 4 years later. And always when they show up on my schedule, it's like, oh, is there something wrong? They just come in to check in and they tell me how great they've been doing, and they just want some other little thing going on, and it's huge. It's huge. And also on another point that you were mentioning earlier, when doing the trial, well, obviously the subjective pain relief is an important factor. But I always ask them about the quality of life, about things that they have noticed differently during that week. And, simple things as the patient comes back and tells me, for the first time after 9 years, I was able to sleep for 6 straight hours without having to wake up. That's huge. That makes a huge difference in the quality of life, in their functionality, in their mood, in their psychiatric health, or when they come back and tell me, I was able to take my dog out and clean up after my dog, which I couldn't. But that's quality of life for them, to be able to enjoy their daily activities without having to suffer from this pain or being worried that when they go out with their dog, they're not able to take care of cleaning up the dog and things like that. So it's amazing. It's an amazing therapy. And most important than all of this, again, as Dr. Chopra mentioned, patient selection is huge. You got to pick it for the right patient. So it's not necessarily for every single patient walking in the door, but it's a great therapy. And if you go through the proper selection of the patients, the outcomes are amazing.
Yeah, I just want to hey guys, this is Dr. Hirsch. I just wanted to jump in and kind of tag along with the doctors here and mention some sort of med legal aspects because I know like there's a lot of lawyers here. So one thing I want to emphasize is the value of the trial itself. So the trial is, it's like it's not a very complicated procedure. It's not permanent. But the good thing about a trial is for you guys is for some of those cases which maybe don't have the exact policy limit that you guys need to get the patient the care they need. What a trial can do is really impact the future medical. And so if they have a successful trial, that in itself is very powerful information that you guys can take to the adjuster or the insurance companies and let them know like, look, this patient has some obvious pain relief from this technology. And so in the future medical, this might require implantation of a spinal cord stimulator. And so one thing I found is that's a very powerful piece of evidence. And because not only that, during the trial period, the companies, the rep usually tracks how they're doing and provides some degree of, as close as you can get, I guess, objective data. One of the things Morad mentioned is, people will mention, how their lifestyle improves. And so during the trial, during the week, oftentimes um, the what do you call it? The rep will track all of this. And so you guys can use that data to your benefit as well, even if they don't necessarily want to necessarily pursue the implant, or if they don't even end up getting the implant. The trial in itself is very useful. And again, like it's a very quick, easy, minimal risk procedure that they should already kind of be familiar with. I always tell patients it's not terribly different than getting an epidural. Obviously, from our end, there's a lot of differences, but from their end, it's a very easy, quick, painless procedure.
Yeah, and I just want to add to that. So I typically, any rep who works with me will vouch for this. I make sure it's mandatory. They need to contact the patient every single day during the trial to document how much percentage pain relief and specifically to look out for what functional improvements they have experienced. So that will definitely, with my trials, that's definitely a part of it. That's something that's very important to me that I always hone in on with each trial.
Yeah, so the same here too. I have every single patient gets trial. I get daily text messages from a rep on the outcomes, and try to be as involved as possible in managing it the way any way we can. But yeah, our daily updates is absolutely important.
Are there any questions from the legal side that, or anything that we may be able to further discuss or elaborate on that may be an issue or anything like that regarding SES?
So, Dr. Chopra, I'm seeing a couple of questions here. One is, are there any permanent negative symptoms or issues that could arise with the trial of CRPS?
So nothing that I would say would be different than for CRPS or any other indication. Typically, I would say the most common thing I experience from patients or I hear about from patients after the trial period, they'll contact me or our office or one of the reps, is that, they're experiencing some relief or not really much. And I always tell them, listen, don't worry. That's why we have this trial period of 5 to 7 days. We're gonna, just be patient with us. Just understand that it is a process. But, if we need to get a rep there once a day, even until we get it right, to that right program that's essentially individualized to that patient, or multiple times a day even, we're going to do what we got to do in this trial period to make sure that we can get this to be a successful trial for this patient.
Right, and there's not really any permanent negative symptoms. So it's like any procedures, there is an inherent risk when we're getting close to nerve roots, we're getting close to spinal column. So there's a very minimally possible risk of injury to any of those structures. But other than that, there's no general risk of long-term damage or permanent issues with any of these procedures.
And we're doing this all fluoroscopy guided, sometimes even live if we need to. And we're constantly taking 2D images to create a 3D image. So, like Murad said, I agree. There are those nearby structures, but if you can do an epidural, you should be able to do an SCS, in my opinion, the trial to get the leads in the epidural space.
Absolutely. And the risk is no more than just doing an epidural.
Mm-hmm. There are two
Yeah.
pinpoint incisions, essentially.
Yeah, from med legal perspective, guys, CRPS is probably one of the most argued against and controversial diagnoses you can make. And almost every single CRPS diagnosis is going to be fought against. The reason for that is the criteria is there's a lot of different things that can fit that criteria, the Budapest criteria. However, that's not the only thing they use. Some people will cite the AMA guides, 6th edition, to kind of fight against it. And then notoriously, some of these sympathetic blocks that they talked about, like the lumbar sympathetic block, sympathetic or the stellate ganglion block. If you look at the ACOEM guidelines, those aren't even being approved anymore, or they're getting harder and harder. So again, I think the trial and documenting some kind of relief from that, again, adds to that preponderance of evidence that you guys need to sort of justify a diagnosis, because CRPS is a life-altering diagnosis, and insurance companies really hate that. But if I was the defense reviewer on the other side of things, and the treatment, the diagnosis was a bit ambiguous, a positive and successful trial would be a very powerful argument against that.
Dr. Hirsch, this is Attorney Farshad. I appreciate your explanation, and I appreciate everybody that's given me kind of your guys' input on this. One of the reasons I was asking this question is I, in particular, have a CRPS case that I'm dealing with, and it's always interesting to me to kind of get perspective on these sort of issues. The one that I'm dealing with in particular, the patient was diagnosed with CRPS at a young age, and he had become, non-symptomatic for most of his, life, and recently post injury, post data loss, has then now had severe symptoms as a result, and he's terrified of getting the trial, the spinal cord stimulator trial, which is why I was asking. My understanding of speaking to a couple other attorneys is that they've had one-off situations. I've heard a couple horror stories from the spinal cord stimulator, which is why I'm wondering, are those just one-offs? Are those just things that happen randomly that you don't see ever again? Really, it seems like that's the case. It seems like the spinal cord stimulator, per kind of what you guys are saying, is no more dangerous, than an epidural, which, yes, you're getting close to, the spine and getting into neurology and all that, but that it doesn't seem like we're putting an inherent risk which is kind of what I had thought, or what I had heard from other attorneys or other people. So that was kind of the point of my question is there something that this person could potentially, get from the trial that could be so negative that could alter their life even more or make it worse for them, with regards to the trial on this?
I personally can't think of anything, to be quite honest with you. Placement-wise, anatomically, it's in the epidural space. You're essentially stimulating, can't worsen the pain. I haven't heard of that. You can't, essentially, if you're doing it under fluoroscopy and you're capable of doing an epidural, you shouldn't pass the epidural space, which I'm thinking of all the possible. It's 5 to 7 days. But if the patient, ultimately you don't have to keep it in for exactly 5 to 7 days. Usually the patients would like to keep it in as long as possible, just because odds are they usually do experience more relief. So ultimately, once we know that, hey, this is successful, we've seen it for a few days now. I've had some patients on chronic anticoagulation. They can't be off of it for too long. After 3 days, if I get what I need with it's successful, I can document it and explain functional improvements as well as percentage improvement of pain. I take it out just to, not get them back restarted on their anticoagulation. But to answer your question, I can't think of anything. I don't know if Dr. Nasseri or Kavishvar, you guys have any?
One thing I would emphasize is obviously you want to have this done in the hands of someone who does it frequently. I mean, if it's just a person who's doing it once in a blue moon, there obviously is increased risk of complications. And as I mentioned, there is inherent risk by being close to those structures. But as Dr. Chopra said, we do this very diligently under fluoroscopy, step by step, following all the landmarks, all the stepwise approach to get the lead where it needs to be. So if all of those are followed, the risk is almost close to zero. I don't think anyone can ever say the risk is zero, but it is very close to zero.
Yeah. The only thing I'll say is so what those other attorneys are probably referring to is when someone has CRPS, let's just say they have CRPS in their foot, they doing let's just say they have like a knee CRPS in that region, and then they need like a arthroscopic knee surgery. Then after that surgery, they have much higher increased risk of making that CRPS worse. So that's why oftentimes you'll see people avoiding doing surgery on the same location as someone has DRPS. Now with the stimulator, this is in a totally different anatomical location. So that's one. That being said, usually probably what they're talking about is if someone does have CRPS, especially post-surgical, they are at increased risk of getting CRPS again after any other surgery. And so that's one, that again, it has to be about patient selection. So you gotta really make sure that their CRPS is under control and really make sure that the benefits outweigh the risks. In other words, if the pain's so bad that they absolutely just need the stimulator, then maybe it's worth that risk of getting that CRPS implanted. So the trial, not so much, but I could see how the implant could potentially trigger CRPS in a new region. But I mean, that's very, very, we do this all the time for CRPS, and so it's exceedingly rare. So I don't know if that's perhaps what your other lawyer friends are kind of referencing.
And I just want to add to that. So if you look at the other side of it too, is that, okay, here is the CRPS that's worsening, clearly has worsened. We see over time, typically CRPS gradually worsens on its own if nothing is being done to treat it too at that point or manage the symptoms. In addition, there's also chances of crossover to the other side with bilateral involvement. So that being said, in my mind, it's, this can only help, right? In the sense of, you're potentially, preventing bilateral, extension of the CRPS too, as well as worsening on that affected side. So I agree with what Dr. Hirsch is saying, but I think if you look at the other side, that's kind of the counter argument to this.
Just had one more question in the chat, Dr. Chopra, from Ethan. What types of physical structural issues prevent from proceeding with spinal cord stimulation? And there's an example, specific spinal stenosis.
Okay, so the question is, what are some of the contraindications or like limitations, like diagnostically?
Yeah, issues prevent from proceeding with.
I think like physically or anatomically.
Gotcha. So, I mean, sometimes if it's failed back surgery syndrome, there's a lot of, there can be some scar tissue, which can make it challenging to enter the epidural space at times. For the most part, it is doable. Sometimes when there's existing hardware, if they've had spine surgery with potential hardware placement, that can sometimes obscure it, make it harder. I would say those are probably the most common limitations, like anatomically speaking.
Thank you. And we have a final interaction. My experience was that California workers' compensation denied me spinal cord stimulation. They quote very old data showing questionable results.
I don't know, Dr. Chopra, if you do workers' comp or not cases, but I have done implants on workers' comp. There are oftentimes appeals that we have to submit, we have to do submit a lot of information, but I do, I mean, it's not always 100% of the time, but I do get approvals quite frequently for workers' comp. But you're absolutely right. They rely on very old data and information. One of the most common things I hear a lot is there's no data to show this. Or they say the physician has not indicated that they have talked to the patient that this device is only good for up to 3 years and nothing more, which is absolutely nonsense because I have patients coming back after 10 years who my partner implanted them, and they just come back for me to do a IPG replacement, which just by itself speaks to how greatly this device is working for them, and they do want to continue with the therapy. So there is a lot of resistance and pushback, but we get them done with workers' comp.
Also, we got Regina Rosa. She wants to know if there are any systematic contraindications like coagulopathy.
So what we do is we do a pre-op assessment. If there is any concern in that regard, we'll get like basic labs to make sure there is no issues with any of this prior to implantation. If there is no pre-existing history of coagulation, this shouldn't. Are you talking about because it's theoretically a foreign body? Is that the question that's being targeted, or just overall coagulopathy?
It looks like it's overall coagulopathy.
Okay. So yeah, it shouldn't really be an issue if there is no pre-existing condition, or all the lab work looks okay. We look at what we call bleeding time. We'll look at the INRs, all of that, the PTT. Those are all specific lab indicators. We'll look at if everything is within normal range. There's no pre-existing history of any coagulopathies. This shouldn't interfere with that or worsen that or cause that.
Well, in that case, Dr. Chopra, I think that those are the last questions that we got in comments. I don't
Awesome.
know if someone else would like to say something.
Okay, well, if that's everything, then I'm gonna thank everybody for their time. I know everyone is so busy, especially after work. So I really appreciate the time everyone took out to listen to my presentation. And I think, it was great to talk and with our colleagues and with all of the input to discuss spinal cord stimulation. So if anybody does have any follow-up questions, we can, Oscar, Amber, you guys can help, give my email. You guys can contact me, Dr. Nasseri or Dr. Hirsch directly. And we'd be more than happy to answer any other questions that do come up. Thank you.
Thank you, Doctor. I also encourage all our attendees to follow Dr. Pooja Chopra on her social media and remind you that you can find more information on this topic and others on the Synergex Med website and social media, as we specialize in pain management and neurology. And I hope you have a good evening, and we'll see you soon for more events. Thank you. Thank you, Doctor.
Bye. Thank you. Have a good evening, everybody.